Ji, Assalamu alaikum. So last, hopefully, but not the least, I know we are very much short of time, so I had good few slides, but I'm going to rush very, very quickly. So just the principles I'll be talking about. I'll try my best not to talk much about the cytokines and the whole jargon of the different, the names of the drugs and all this. So the basic principles, what we should be talking. So the layout, again, about the disease, talking about the window of opportunity, about the referral pathways, and a little bit about what the management should be looking like. So about the disease, we know it's a common enough disease. It's one of the most common inflammatory arthritis, autoimmune arthritis we talk about. It can happen at any age. Usually we know that it is usually the middle age, between the age of 20 to 40. But we do see patients what we call elderly onset rheumatoid arthritis. And we do see quite commonly patients around the age of 70 to 80 do have seropositive rheumatoid arthritis. So no age is spared of this particular disease, but usually, as we know, it's in the middle age. And we know the women folk are mostly affected with this disease compared to the men, and around 3% of the women are considered to be at risk to develop rheumatoid arthritis. Again, as we can see from the left-hand one, of course, it could be initially just the pain, then gradually very subtle swelling, and then, of course, if it gets unchecked, untreated, and then leads to the deformities, which of course we all know about. Extra-articular manifestations, little bit that you need to be aware of, just because patients do present late. It's a chronic disease, it's a long-standing, lifelong, mostly in most of the cases disease. So there's a lot of extra-articular manifestations. For example, the nodules, forget about the nodules, very commonly people get what we call sicca symptoms, means dry eyes and dry mouth. Very late stages, they present with vasculitis, means the gangrene in the different, for example, the toes or the fingers. So we need to be a little bit mindful of those things as well. So what, as a rheumatologist, what we are interested in from you guys? Of course, firstly, to find out like what particular pattern of arthritis is. Are we talking about polyarthritis, oligoarthritis, or of course monoarthritis? And again, very importantly, as we all know about the morning stiffness, which also simply tells us about the inflammation. Inflammation, in simple words, is like a gel phenomena. So when a patient sits in one position for a longer period of time, the joints get frozen. So they get like sort of the stiffness. That's why the inflammatory pain is worse at the late nights or the early mornings compared to the rest of the day. And naturally, it's a chronic disease, the persistence, the chronicity, lasting more than 6 weeks. So in examination, so this is S sign, or S factor is considered as one of the very sort of the specific one. Means there is a stiffness there, as I said, the morning stiffness. There is a swelling of the joints, not just the tender joints, but the swollen joints. So when you palpate the joints, when you feel the joints, there is a tenderness there. And of course, the squeeze sign, that's also for a common sort of people, and especially in the general practice, for example, if you see somebody, there's a joint pain there, you try to squeeze that particular joint, and if there's a tenderness there, along with the swelling, this is one of the very specific signs that there's an underlying inflammatory arthritis happening. So this is how we generally try to do. Rather than looking at the individual joint and trying to palpate and looking for tenderness, so this is like the whole MCP joints that you just try to hold on to, just like you're shaking a hand. And also the same goes with the MTPs, that you can simply squeeze them and see if there is a tenderness in a patient where there is, for example, the pain there. So these are the simple things which can help us. So talking about the window of opportunity, this has gained major momentum, at least in the last couple of years, at least in the last 2 decades or rather, I must say. In simply, window of opportunity talks about that there is a time frame, that if we act in that particular time frame, we get much superior results, and there is a much higher chances of achieving remission. Not just the remission, but also that the drugs can be taken off, the disease or the drug-free remission is an achievable goal. And we know that the inflammation only happens when it gets unchecked, and the damage, in other words, only happens when the inflammation goes unchecked. For example, what we're seeing uncontrolled, and it leads to the deformities that we all are aware of, the ulnar deviations and so on. And that happens only if the inflammation remains uncontrolled. So this is the patient, just like a normal X-ray. You know, the usually patients, the compliance is always an issue. The moment patient gets better, the last they want to know is to consult their physician. Again, the year delay of the treatment, and that's what happens. There is a full-blown sort of erosion developing in the MCP joints. So delay to diagnosis, if we talk about like why the story there in terms of the delay to diagnosis. For example, if you look at the bottom one, the green one, so these are the patients who were treated within 2 weeks of their symptom onset. So within 2 weeks of the symptom onset, these patients were treated, and the other one were the patients who were treated, well managed, within 4 months, around the 4 months of their symptom onset. And what you're clearly seeing is the difference of the radiographic damage, means the X-ray damage, means the joint deformity is happening even within 4 months of the delay of starting the recommended or the effective treatments. So this short delay even can be enough to have long-term issues. So this is one of the the diagnosis, the psoriatic arthritis. This is one of our studies, and what it shows was the same, that if there's a 6-month delay, what particular damage is happening, if there's a 1-year delay, if there's a 2 years delay, and it's a phenomenal that there is, the longer the delay, the more long-term damage happens. And again, talking about what happens about these patients who we talk about that there's a delay to diagnosis, it means these are not the patients who are sitting at home. I mean, these are the patients, again, who had the delayed sort of the diagnosis, who presented late. When we inquired about them, where were they hanging around those times? And you are be amazed to hear that more than 60 to 70% of these patients who eventually landed in a rheumatology setting and got their diagnosis have already been wandering around with different disciplines looking for help. Unfortunately, the proper referral pathways are not established. So window of opportunity, as I mentioned, initially, number of years ago, we used to talk about 2 years, that we should be talking about treatment within 2 years, but that is a very long time ago, of course. In last 10 years, then it got reduced down to 6 months, then to 3 months. And now what we are talking about is the pre-RA thing. And this is very important to understand. So you're talking about a healthy patient who develops then gradually arthralgias. Again, who doesn't have joint pains? A lot of people could develop arthralgias, and then gradually it develops into undifferentiated arthritis. And then it leads to rheumatoid arthritis, and then there's a progressive. So earlier on, they were talking about this particular window of opportunity, that we should be acting around this with a very effective, the top-notch, whatever drugs we have. But now we are talking about acting it here, or rather at this level. And that is the time when we should be talking, and that is only 2 to 4 weeks' time of somebody developing arthralgias. At that time, to look at the risk factors and some sort of the blood work as well around those times. The other concept we need to be knowing about is the treat to target. This is the concept that we borrowed mostly from the diabetologists. For example, they're talking about HbA1c, that there should be target in their mind. So we do have a target in our mind, and that is that there should be no tender joint counts, there should be no swollen joint counts when we are talking about a patient with the rheumatoid arthritis. So setting a target, then regularly testing them after at least 4 weeks' time, and if that target is not achieved, we need to keep on escalating the treatment, because we know that one drug doesn't fit all, and we have wonderful drugs to hand. And the other important thing in the treat to target is that it should be a shared decision with the patient. So I should be making the decision, sitting with the patient, talking to them. Again, in Pakistan, of course, the most important thing is about the pocket as well. Of course, we have wonderful, wonderful drugs, almost all the drugs available in Pakistan. Of course, it all depends on the pocket of the patient as well. So you need to take into consideration about a lot of other things. The problem in arthritis, again, we need to be knowing as well perception, because all the time we hear this, and it's, of course, it's heartbreaking that nothing can be done. ये तो पूरी उम्र चलनी है, तो दवाइयाँ खाते रहो ठीक रहोगे. But at the same time, of course, it's a disabling disease. Again, of course, the priorities, of course, there are much better priorities, of course, strokes and you name it. Of course, the arthritis comes a little bit in the lower priority list, so that's why that's another problem. But if you look at the real sort of the evidence, or in terms of the statistics, if you like, so every fourth person, not the patient, sorry, in United States figures, that's the consensus there, census there, that every fourth person walking around in the United States have some form of arthritis, either it's osteoarthritis or some of the other types of arthritis. And 2/3 of the patient with arthritis meet legal definition of disability. 2/3 of the patient. So this is such a horrendous disease. And even talking about the general practitioners, for example, so the 1/4 of almost a daily sort of the consultation to you guys is usually considered to be related to some form of MSK or arthritis-related symptoms. In moderate disability, it happens within 2 years of diagnosis. 2 years of diagnosis, there is a moderate physical disability. And within 10 years, of course, there is a major disability. Around 50% of the rheumatoid arthritis patient, 50% within 10 years, they will not be able to work. So that's the state of affairs when you talk of. So management, again, we should be talking about not just the pain, of course, a lot of other things, controlling the disease, controlling the inflammation, and of course, would require MDT approach. There's a lot of ways we look at in terms of, we know about the methotrexate, which is the anchor drug, means is the starter drug. And then, of course, we go with the combination drugs. We have the biologics and so many other drugs. I won't bore you with all their names, but just as I said, we need to be knowing that most of the top-notch drugs that we talk about are available in Pakistan. Again, the price is an issue, but for most of the centers, at least in Lahore, not our Fatima Memorial, but a lot of other centers, alhamdulillah, they're working very well, and they are supporting those people who cannot afford. So just for the primary care folks, so while you're waiting for there are a lot of things that you can do. For example, if you're knowing that the patient does have, for example, tenderness, does have a swollen joint, does have, for example, the rheumatoid factor positive, so you should be thinking about adding some of those things. For example, NSAID, of course, naturally. Low dose of steroids you can try, at least in the short run, unless they seek a specialist care. And the DMARDs, of course, again, if you're confident, there's a very high the rheumatoid factor, for example, and you're very clear, of course. I mean, I'm sure you must have seen loads and loads of rheumatoid arthritis patients. If you're confident enough, then low dose of any of the DMARDs can be introduced if there is a delay in seeking a specialist care, because I mentioned the time is unfortunately a major problem that leads to the damage in the long run. The DMARDs, you might have heard, is a very fancy name, disease-modifying anti-rheumatic drugs. So these are all the different drugs land in this particular category. There are different types. One is our conventional synthetic DMARDs, means our historic, the methotrexate, HCQ, and so on. Then there are biologic drugs. These that usually come in the injection form, either the subcut or intravenous. And now we have the latest, what we call targeted synthetic DMARDs, also in the tablet form as well, which is relatively a lot cheaper. So as I said, the methotrexate, most of the people think that is one of the universal drug, one of the major drug. But if you look at all the studies, only 1/4 to maximum 1/2 of the patients with the rheumatoid arthritis respond fully to methotrexate. Means around 1/2 to 2/3 of the patient do not respond fully to methotrexate. They respond only partially to methotrexate. Means that we need to be thinking about some other drugs. And of course, these are the next in line drugs. And the biologic drugs, they work as regards the cytokines, the pro-inflammatory cytokines, the anti-inflammatory cytokines. So they try to achieve that balance. And there are loads and loads of available, and they're very effective ones. Only problem is the cost. Only problem is that they come in subcut form or intravenous form. But the very important thing to now look at, and these are multiple studies, and they're talking about, again, the biologic treatments have absolutely revolutionized the treatment. Absolutely revolutionized. You'll be amazed to hear when I came back to Pakistan, for my final year medical students in Ireland, I really struggled to find patients who have deformities for their final year exam. Because in rheumatoid arthritis, in our rheumatology clinics, we hardly found the patients who have deformities, unless there is some historic old patient. So these biologics have revolutionized, as I said, the treatment. But here the studies, and what they're talking about is that this is a triple therapy, means I'm talking about these cheap drugs, for example, HCQ, methotrexate, leflunomide, for example. If you try these drugs in a better combination, for example, triple therapy versus a biologic drug, what we're looking at here is at 6 months and almost a year time, there's no major difference in their outcome. Means that the biologic drugs are absolutely wonderful. But at the same time, with the proper cheap drugs in better combination, we can achieve very good results. And the same is another one. What they're looking at is the radiographic damage, even up to 100 weeks, there was very good results, no matter whether you treat a biologic or with a better combination of cheap DMARDs, if you like. We know most of the patients die in rheumatoid arthritis. The most common, the top one mortality reason is cardiovascular. And this was one of our studies. And what it showed is very important to understand, that the most of the patients, they die, as I said, from the cardiovascular risk factors, cardiovascular diseases. So they do not die because they have this worse, the BMI, the metabolic syndrome, their poor lipid profile, but they mostly die because of their underlying disease severity. And this is, since then, has been replicated in other studies as well. So what I wanted to say in simple word is that when the inflammation remains unchecked, when the inflammation remains uncontrolled, that actually is a much higher risk factor for heart attacks, for strokes, compared to your conventional high cholesterols or the BMI and all this. So that is another reason, not just talking about protecting the joints, but also it's a very important factor to protect their heart and protect their strokes as well by controlling a better disease activity. So this is the last slide. So early diagnosis, of course, that is the key. So that's why people consider it as it's a relatively medical emergency, because we can prevent the development of rheumatoid arthritis if we intervene early, if we intervene at the stage when there is a simple arthralgias or undifferentiated arthritis. And early treatment is the key. And we have very wonderful drugs available, and they are as good, they're cheap, and of course they can be quite effective at the same time. Thank you.